Hi, you guys. My name is AJ Pearson. I am giving you my poster presentation today for our senior synthesis class. I did my presentation on sepsis and hourly antibiotic administration. We're trying to administer the antibiotics within an hour of the doctor's order for our patients presenting to the emergency department with sepsis. I think it is worth noting that I work in a rural emergency department. We are a 14-bed emergency department. I also work in a larger facility, but I did my project in the rural setting. So we are trying to identify barriers that are keeping us from this hourly administration, and the barriers that we have in the rural setting are much different than they would be in a bigger hospital. We have a staff that supports one doctor at a time, two nurses at a time, one respiratory therapist, one radiology tech, and one lab tech. So we're very small. Our resources are a little bit limited. Those of you who work at a hospital, I'm sure, are fully aware of sepsis protocols in your facility, regardless of the department that you work in. But I do want to note that the barriers that we looked at have to do with a very small staff and limited resources. So I will go ahead and get started. I apologize. I tried to film this at work so that I had an extra set of hands to film, but we were too busy. So now I will be filming this by myself. So bear with me. So I wanted to start out a little bit talking about the pathophysiology of sepsis, and I wanted to talk about the background and the purpose of my project. Before COVID-19 hit, this was a huge issue in our facility that we were working on. We were really trying to improve patient outcomes and tighten up some of our nursing protocols. When COVID-19 hit, this was put on the back burner. So I'm hoping that this project can help us get back on track when things settle down around our facility. So first I wanted to talk about sepsis and what it is. So a patient who presents with a normal infection, you're looking at someone with a healthy immune system that responds and provides a protective response, killing infection and maintaining organ perfusion. In sepsis, the immune system produces an excessive or poorly regulated response with an outpouring of inflammatory mediators, and this causes organ dysfunction. So these various inflammatory agents attack the endothelium of the capillaries, causing microvascular thrombosis. As the capillary beds of various organs plug up, perfusion fails, and eventually ischemia occurs with subsequent organ failure. So it's these mediators that directly injure the capillary endothelium, and this results in thrombosis, loss of perfusion, and tissue hypoxia. So that's the real hallmark of sepsis. So it's not just a poorly controlled infection, but it's also an acute circulatory dysfunction process, and that's why we really want to try to catch sepsis as fast as we can and treat it as fast as we can. So we're always trying to identify sepsis early. We have a set of criteria. We call it our Sears criteria, and I think this is probably pretty familiar to a lot of you. So you're looking for tachycardia. We're looking for a heart rate over 90. Usually they're breathing pretty quick, a respiration rate of over 20. They could be febrile. They could have a high white count. And then you're also asking yourself, does your patient have an infection or could they have an infection? Sometimes this is difficult to decipher. A lot of times, especially in the emergency department, you're getting patients who either aren't giving you a great medical history. A lot of times they can't talk to you for whatever reason. In my particular town, we do have a lot of tourism. So you're handling patients that you don't necessarily have access to their medical records right away either. So you're always asking yourself a few questions. Again, could my patient have an infection? Well, are they in the hospital or the emergency department? In my case, they always are, so that's a high risk for infection. Also, do they have a chronic condition? This puts them at a high risk for infection as well. So I tacked on a list of our algorithm that we're using at this time. It talks about the Sears criteria. Typically, if people are showing up with two or more of these criteria, we start to utilize our nursing sepsis protocols. So this walks us through our algorithm. It's pretty basic, and this is what we've been operating with for a really long time now. So we were trying to tighten this up a little bit. So when you do get those patients that you're not getting a great history from, that's when you have to start using your nursing judgment. So you're looking for a few things. Is your patient over 65 years of age? Are they a post-surgical patient? This is a huge risk for infection. Are they coming from a nursing home? Are they immunocompromised? Do they have cancer? Are they going through chemo? Do they have indwelling lines and catheters? Are they currently using antibiotics? Are they alcohol users or drug users? Another thing that you can look at, does your patient have a wound? We're doing a lot of chest x-rays. We're looking for pneumonia. Do they have a urinary or a kidney infection? Do they have an acute abdominal infection? Are we dealing with endocarditis? Do they have an extensive cardiac history? Or do they have indwelling lines or central lines? And this is something we see a lot with our cancer patients or patients going through chemo. So we'll talk about septic shock a little bit here. So it has distributive, hypovolemic, and cardiogenic components that are simultaneously occurring. So you're looking at a few different things. Distributive shock, this is tissue hypoperfusion despite normal or high cardiac output because of the macro and microvascular inflammatory thrombosis. So this tissue hypoxia sets off its own cascade. Hypovolemic shock is an inflammatory thrombosis, and endotoxins cause third spacing of capillary fluid, which leads to hypovolemia. The last type of shock is cardiogenic, and this is due to distributive and hypovolemic shock. And this is a case where your cardiac output is going to collapse. So we're looking to stop sepsis in its path. You really don't want it to get to the point where your patient is in septic shock. And this is a slippery slope. It can happen pretty quick. A lot of people that come to the ER have already been experiencing sepsis for some time before they've come to seek medical help. So you really want to try to act quickly. Again, this is a flow sheet that we utilize. It talks about the arrival of our patients and walks us through kind of what we need to do until their departure or their admission to the hospital. Also, we do end up flying a lot of patients from our rural facility for a higher level of care. So this helps us make those decisions. But the biggest thing that we need to remember is to stop sepsis in its tracks. So my project is focusing around broad spectrum antibiotics, and that's the one thing that can really stop the septic cascade. Mortality can increase by 8% for every 8-hour delay in antibiotics. For every hour delay. Over 80% of our patients in my ER present to the hospital with sepsis already present. So it's important to ensure that we are administering these antibiotics within 1 hour of the doctor's order. If the provider is considering an infection, it's really important to make sure that they're putting in those antibiotic orders. The other thing that we have that I think you're probably familiar with in your own facilities are our sepsis bundles. So you're looking at a 3-hour bundle and a 6-hour bundle. The 6-hour bundle is a little bit outside of my realm. Usually my patients are gone by the time we're at this point. So I am a little more focused on the 3-hour bundle and the emergency department. This includes bilateral IV access, drawing lactates, getting your blood cultures, and starting your antibiotic and your fluid boluses. In your imaging. Those are the things that we kind of include in that bundle that we try to get within that allotted time frame. So our current time frame, the 3-hour bundle, also included our antibiotic administration. So we weren't necessarily totally focused on an hour administration of antibiotics. So we're trying to bump up that time just a little bit. So I made kind of a fun little cartoon here. So we get to work. We get our 2 lines. You get your 2 sets of cultures from different areas on the patients, and this helps identify our infection source. You get that fluid bolus ready, and then you get your antibiotics. But if your Pyxis is like ours, that's almost never working, or you're locked out of it, or something's going on with it and it holds you up. So this is the ideal situation, but what happens if this isn't working? What happens if anything gets thrown in your plans here and you can't make one of these things happen? So another support and evidence, every delay in administration of antibiotics causes a higher mortality rate. So the survival of your patients really depends on you having all of these steps in place and being able to get all these things done as soon as you can. Obviously, you can't administer antibiotics without your peripheral IVs. And we try not to start antibiotics without getting your 2 sets of cultures because we really want to be able to identify that infection source. So those are a couple barriers that we were finding, and I'll talk more about those in just a minute here. And then I've got a picture of one of my coworkers and I. and my red Jello lactates here. So that's my first lactate and our 4-hour lactate after that. So this brings me to my PICO question. What barriers exist which prevent administration of empirically appropriate antibiotics to septic patients presenting to the emergency department within 1 hour of a physician's order, and will the elimination of these barriers improve antibiotic administration times? So, for our theory, I had several of my coworkers write down personal barriers that they had to the administration of antibiotics. Everybody had a few different things, so I collected some of their opinions just to kind of see what their biggest holdups were. This is something that we are dealing with in our ER, so I wanted to really get everybody's opinion. So I got a couple of our RNs, a few of our doctors, just to kind of see what their thoughts were. So we'll address those more in just a minute here. We did talk about those barriers together, and we also came up with a couple of solutions. But firstly, I wanted to address our goal within my theory. So our goal in my emergency department is to get antibiotics within 1 hour of the doctor's order, and currently it's taking us about 131 minutes. So this is significantly longer than an hour. Delays in antibiotics, again, cause mortality by 8% for every hour delay. Sepsis is a medical emergency, and the risk of death increases with delayed recognition and treatment. So our goal is to start the antibiotics within 1 hour of the physician order. I'll talk about a sepsis alert pretty soon here. We don't actually have an official alert. That was something that we were working on before this COVID-19 hit, and so I'm really hoping that we can get that back on track soon here. And then I threw a little bag of fluid on there. So implementation of this project. Again, the staff and I talked about different barriers. So when we were talking about personal barriers that we had to antibiotic administration, I wrote down the most common ones. Difficult IV access is a huge one. You have patients that are coming in that are very sick, very dehydrated, hypotensive, and it can be really difficult to access those veins. Blood culture collection was a huge one. We were really trying to get those cultures before we administered antibiotics because you don't want to skew those results. Availability of antibiotics and pharmacy mixing times. So again, I work in a rural facility, so our resources can be very limited, and we do only have one pharmacist on staff at a time. So they are working for our OB department, for OR, for med-surg, so they can be very busy and not necessarily have enough time to mix our antibiotics for us. We do often get patients come in who are actively coding. It's really difficult to focus on sepsis interventions when you are trying to keep somebody alive. Variable presentations. This is a huge one. It can be really hard to collect that history again for a patient. Some patients come in and they are visibly septic, and you can tell almost right when they come through the door. But some patients are walking in and they're pink and dry and healthy and talking, and they just don't look very septic to you at all. Limited history from a patient. Again, not everybody knows their medical history, or we're getting patients from out of town and we don't have access to their records. Diagnostic imaging, we only have one radiology tech at a time, so it can be difficult for us to get imaging that's important, such as those chest x-rays, because again, they're working over an OB and med-surg and OR, so they can be wrapped up and not be able to get to the emergency department quickly. Additional critical patients. Like I said, we only have one doctor and 2 nurses on staff. It's pretty often that we'll have multi-traumas or several critical patients at once, and so it can be difficult to focus on that one septic patient when you have patients that are perhaps presenting more critical at the time. And then a lot of our doctors mentioned logistics of ordering medication. We just switched over to the Epic charting system about 2 or 3 years ago now. There's still a couple of lumps in our charting that we're trying to smooth out, and so they can have some difficulty placing orders. So then we started talking about solutions. This is kind of a confusing chart over the phone, so I'm just going to go one by one here. So we were talking about initiating sepsis alerts before COVID-19. So that's something that we are working on. We do have the capability through Epic, but it is going to require a little more education for our staff, and then just remembering to do that, because that's something we were not doing before. And starting sepsis bundles utilizing collaborative practice orders. So we also are pretty new with collaborative practice orders. This gives us the ability to order for the doctor without them needing to come and see the patient and sit down and spend all that time. So we can actually get the ball rolling on our own if our doctor is wrapped up with a different critical patient. Rapid response teams are huge. I think it is really hard for our staff to remember to communicate with other members of the hospital. So, pulling our house supervisor over, making sure that you're calling pharmacy and radiology and getting everyone on the same page, the quicker that you can make those phone calls, the quicker that people can get to you. So, really utilizing your team and really amping up communication is going to be huge for us. Your rapid response team can help you place IVs. So if you have a patient that's coding or you're having difficulty getting that placement, it's always helpful to have an extra set of hands and eyes to help you do that, and you can start working on other things that are important as well. By calling that sepsis alert, radiology, pharmacy, and lab are notified, and they can respond. Obviously, not necessarily stat in my situation, but again, that quick communication can help them get over to us a little bit quicker. And now we are no longer prolonging administration of antibiotics to obtain blood cultures. Obviously, you can probably get one set because you do need to have that peripheral line or EJ to administer the antibiotics, unless you're doing it IM. But we really like those IV antibiotics, and you typically can at least get one set of cultures. But if that's something that's holding you up, we're not really worrying about that anymore. We do want to give it at least 1 or 2 tries, but if we can't get it, we're going to go ahead and just give that antibiotic. So we had a few other things. We did start working up the sepsis alert activation call list. This is a really good cue for us, and it helps us remember how important this is. We have an activation call list for traumas, and we also have one for cardiac and stroke patients. So it kind of just helps remember who to call. You can get those times notified so we can start working on times and getting that people there faster, and just kind of tracking how long it takes us to pull all of this together. We do also have a report checklist. So I tacked on our old one. This talks about the antibiotics started within 3 hours of arrival. So that's, again, something that I'm trying to change through the implementation of this project. So we made a new one that really indicates that you need to try to get the antibiotics started within 1 hour of the emergency department physician's order or your collaborative order. Also, we have a lot of capability through Epic. There's a lot of triggers that help us identify these patients if we're having a difficult time doing it ourselves. So we did start implementing the sepsis screening alert. It is in our rapid intake in the ER. So the rapid intake is the initial charting that you do for a patient. It includes your vitals, it includes medications, allergies, just kind of important right off the bat information that you need to know. This you can trigger. It talks about, does your patient have a fever? Do they have mental status changes? Kind of triggers that might start leading you to believe that they could be septic and you need to start acting. The problem was that when they implemented this screening alert, they implemented several others at the same time. So it became a little overwhelming, and it also made our rapid intake not quite as rapid. So people started skipping over this step, which is definitely something we don't want to do. We really want to focus on people going through this extra step, and it just kind of helps us keep track and mark patients that could have these risk factors. We did actually just send out some education 2 days ago. It didn't really have anything to do with my project, but really we went through each employee and helped sign people off to indicate the importance of completing this screening tool. Maybe even on top of some of the other ones that were implemented, even if we're in a really big hurry. The other things we have are alerts. So we have a potential sepsis BPA that populates, and we also have a sepsis alert BPA. These are relatively new. They don't actually populate for us quite yet, but they are going to. So I tacked on some pictures of those. So these will help track some of the things that you're charting. So if you're charting vitals or you're charting some other information, and maybe you didn't personally tie together that this could be leading towards sepsis, these will populate and encourage you to start ordering collaborative practice orders and indicating that this patient could be septic. So if you're on a totally different track in your mind with a patient, this system will start to pick up different things that you're charting and remind you that we could we could need to start considering that the patient is septic and that we need to start implementing some of our protocols. This talks about our sepsis alert that we were really working on and that I'm hoping to implement sooner than later. So it talks about our SEERS criteria and then the BPAs that I showed you down here. And it just talks about kind of what we need to do. It talks about the importance of calling a sepsis alert. Data has shown that the patients who meet sepsis parameters and have a sepsis alert called meet the full sepsis bundle requirements 92% of the time. So these are pretty accurate. They're picking up our charting, they're helping us redirect our focus, and 92% of the time they're right. Patients with sepsis alerts and full bundle compliance have a decreased mortality risk by over 10%. So that's huge. That's a huge amount of patients, especially in our tiny ER. That's a very large amount of patients. What patients qualify for a sepsis alert? So patients with a positive sepsis screening, that was the first screening that I showed you that I mentioned we were kind of skipping over because it was making our rapid intake a little less rapid. This means that they have met the following criteria. So they have a suspected or known infection. They meet 2 or more of the SEERS criteria. Their lactate is greater than 2. Their systolic blood pressure is over 90, or they have a MAP of over 65. This patient, or I'm sorry, under 90 and under 65. These patients may have the severe sepsis BPA fire. And again, we don't have that happening quite yet, but it should here pretty soon. Also, as far as implementation, I did implement, and I should have pulled it up here, but I did implement a PowerPoint presentation. It has information pretty similar to the information on this poster. And then I hung a flyer up at the nurses station. I wanted to hang it in more visible places, but our ER is currently under construction as well. So the nurses station was the best place for people to see. I'm just really encouraging them to take a look at my PowerPoint and to take a look at some of the personal statistics that we had. I couldn't include all of our personal statistics on this poster board because I did not have permission to do so, but we had some data directly correlated with our specific ER and specific staff members to kind of just help drive the idea home that initiating some of these things and taking some of those extra steps really help decrease mortality rates and improve our patient outcomes. And I think it really opened a lot of people's eyes, and I did get a lot of compliments on that PowerPoint. So after that PowerPoint, I want to say that it's been about a month and a half since my PowerPoint went out, and since I've had flyers hanging up at the nurses station. So since then, we did start playing around with calling sepsis alerts. So it's not an enforced intervention that we're taking, but we do have the capability to do it. So we were able to track people's progress with calling a sepsis alert and activating the rapid response team. This is what we found. When we call a sepsis alert, we are likely to meet all the 3-hour sepsis bundles 92% of the time. So remember, before it was taking us about 131 minutes to get the ball rolling, and now we are able to meet all of these criteria 92% of the time. So median time to antibiotics with the alert versus without the alert. Our sepsis alert, when we initiated it and activated our rapid response team, was 24 minutes. Before, when we were not activating that alert or our rapid response team, it was taking us 99 minutes. That's a significant improvement in time in antibiotic administration. So I'm very proud of our staff, and I'm really appreciative to my coworkers for taking this project seriously and really helping me try some of these strategies, coming up with some of these barriers and coming up with solutions to these barriers. Obviously, we are in over our heads with different situations at this time. We are also seeing a smaller volume of patients because people are really trying to stay out of the emergency department right now. But what we did have and the opportunities that we had, people really stepped up and helped make my project pretty great. So I hope that you were able to take away some good information. Oh, here, I'll show one more time my reference page. And I hope that you're able to implement some of these things in your daily work. I'd love to get a little feedback from you, people who've been using Epic for a while, people who work in the emergency department, or even other departments. If you have any thoughts or ideas for our staff, they would be warmly welcomed. And thank you for listening to my report. I hope that everybody is staying safe and healthy and keeping up in school. Good luck, you guys, and take care.